My name is Jackie, and I'm the Roman Catholic chaplain for the Diocese of Saskatoon. I'm the coordinator, and I work with a priest, Father Emmanuel, so we work as a team. And years ago, I started in spiritual care at St. Paul's Hospital, and so I was working in the health authority. I was an employee of St. Paul's Hospital, and I was working in spiritual care, and our spiritual care team there were interdenominational chaplains. So we didn't claim any denomination when we met with patients. We were open to all faiths. And that was in a faith-based hospital. So now I've completely reversed that, and now I'm a denominational chaplain, which means I'm specific to the Roman Catholic faith, working in a public hospital, which is like everything. So it definitely has its challenges. Working as a faith-based chaplain in a public sphere is very challenging. We do meet a lot. Us chaplains do meet a lot. We do a lot of discussing and talking. We have our own groups because some of the Canadian laws, which they're there. The public hospital follows and supports a lot of these laws that are contrary to our Christian faith and our Christian belief. And so how do we deal with that as denominational chaplains or as chaplains working in the public sector? So what I want to do is just go over, there we go. I want to start with euthanasia, and then before I go into palliative care, because what I want to do is make it very clear how different they are. Because I find some of the struggles with people who have loved ones who are at end-of-life care in the hospital, maybe on life support, are afraid to make final decisions because they don't know if it's euthanasia or not. Is this something that's okay or not? And so there's a lot of gray areas that people don't understand, or there's a lot of confusion. And so what I want to do is help with those gray areas to bring clarification. And what I want to do at the end is have time for a question and answer. So if there's anything that's you're unsure of or something that wasn't clear, please ask, because what I want to make sure is that there's no confusion when I'm done, so that it's very clear to you what is or what isn't, right? And also at the end, if anyone has an experience that you feel compelled to share, because we might all learn from it, please feel free in that, and question and answer time too. So just to be clear, what is euthanasia? Euthanasia is death by removal of nutrition and also an ongoing life support. So it's a deliberate killing of someone with or without their consent. And without their consent, I know that with our previous euthanasia law, it had to be consent. So when someone wanted what's called medical assistance in dying, they made a request, they filled out a form, and if they were assessed that yes, you can, then they picked a date. So that was the first consent. The second consent is just before the needle goes in that person's arm on the day that they've picked to die. They have to consent to it again, a second consent. Now with Bill C-7, which has been passed, that second consent has been waived. In fact, even the first consent has been waived. So whereas before, a person could not consent to MAiD or request it in their advanced healthcare directive. They had to be able to verbalize it. So now they can. You can put it in a healthcare directive. So that if people lose capacity at some point and become cognitively unable to request medical assistance in dying, it'll still happen for them. Whether they might change their mind or not, it'll still be carried through. So that's one of the changes that have been made. So it can be with and now without their consent. In that final moment before the needle goes in, they don't have to say yes again, right? Euthanasia is also an act where something is directly given or something is taken away. For instance, actually the process for euthanasia here in the province of Saskatchewan, or probably the most widely used method, is an overdose of anesthetic. And so the person is prepped like they would be for surgery. The only thing is they're overdosed and they never wake up, right? In the example where something is removed, it would be nutrition or hydration. In fact, so the person would be starved to death. And that actually happened in Saskatoon. In the first year of legalization of euthanasia, one of the doctors who was chosen to perform MAiD in Saskatchewan called a number of us hospital chaplains to a meeting because she wanted to talk to us. And so she gave us statistics for the first year of what MAiD was like in Saskatchewan, and she also wanted to let us know her boundaries and that how stringent she was, that not everyone that wants MAiD is going to get it. They have very stringent guidelines. And Saskatchewan actually does have very stringent guidelines, not like some of the other provinces. But she told us a story about a woman in a nursing home who was starved to death. She had two daughters. One was the proxy who was in charge, and the other one wasn't. And so the nursing home called, mother's at end of life, death could be imminent. So the daughter, who was the spokesperson, who legally was the spokesperson, said, okay, no more nutrition, no more hydration for mom. And what happened is she didn't die. And she didn't die, and she didn't die. And so after a month of no nutrition and hydration, she passed away. And the MAiD doctor said directly to us, that was euthanasia. That was, she was starved to death. The other daughter was helpless because she had no voice. And so it does happen, and it did happen. They don't want things like that to happen, but it does. And I think I'll talk a little bit later on how important food and nutrition is actually a basic right. And it's, many of the past popes, and I know a lot of Christian leaders have said that food and nutrition is a basic right. It's not something that we euthanize people with. It's a basic right to continue with food and nutrition and hydration. The process to obtain MAiD, and that's medical assistance in dying in Saskatchewan, is a patient-driven process, and the person must request it themselves. And if you go to the government guidelines, it strictly says the process on the government page, the process for MAiD. The first box is patient must request information. And then the second box is patient is given information about MAiD and alternative therapies and supports. So it's supposed to happen simultaneously, that they not only hear about the MAiD process, but they're also supposed to hear about palliative care or all other alternative end-of-life measures. And that's not happening. What isn't happening first is the patient isn't necessarily requesting, it's being advertised. And this is the struggle that we have in the public hospitals, is that no distinctions are being made. There are healthcare staff who just believe it's their right to advertise that euthanasia is available. And they feel it's their right to let patients know. It's a patient-driven process, in that it's there, it's legal. If a patient wants it, then they'll talk to them about it, not the other way around. But it is happening, where it's being advertised, and what happens then is when patients are approached and said, the line is, medical assistance in dying is available if you should so choose. And if they say no, I've actually been in conversation. I had a good friend of mine who died after a year in RUH, and she also suffered from depression. And she was on medication for depression. And she was being supported by lots of our volunteers, our support system. And one day the physiotherapist was in the room with her, and April, I'll call her April because before she died, I asked if I could use her story, and she said yes, and she said, call me April. And so April was in a depression, and the physiotherapist was in the room with her, and April had said, I just want this to be over. I want to die. I want to die. And she clearly did want to die. She'd been in the hospital for over a year. She had 21 surgeries from age 16 to in her 40s. She had maybe just a small portion of bowel left. She was going through a lot of suffering, but she was a very strong Christian woman. And so the physiotherapist, the first thing out of her mouth was, well, medical assistance in dying is available if you so choose. And April was horrified. She said no, and then the physiotherapist left. And afterwards, April called me. She was sobbing on the phone, and she said, I was just told that I could kill myself if I wanted to. And I was so angry. I was so angry. And, you know, you need a place to go and take that anger, because you don't want to go and chew nurses' ears off after that, because we have to stay. We need a good working relationship here. And so I did. I talked. I shared. And on a follow-up meeting with April, I asked her, what did you want to hear from that physiotherapist when you said I want to die? And she said, I wanted her to say, can I get someone to help you with that? Do you want someone to talk to? Do you want to talk more about that? Are you okay with talking to me? She said, that's what I wanted to hear. Tell me more. And that's what's not happening, is when patients are depressed or struggling. Yes, it's a struggle. End of life is a struggle. And yeah, there might be that temptation. I just want this to be over. But when you have someone who believes that a type of treatment is MAiD, well, that's what they're going to offer. And they're not making distinctions. They're asking a lot of people, right? So I like what Cardinal Tom Collins said. He said, let's call it a lethal injection, because that's what it is. You know, they use the MAiD language. They soften the tones, and they take palliative care language and adopt it to soften the tones, because MAiD sounds better than euthanasia. Okay, I think... Oh. Okay, so euthanasia does not include when a refusal or a discontinuation of treatment. When burdens of treatment outweigh its benefits. And methods of treatment can actually become overly burdensome, and in those cases, from an ethical standpoint, they are considered unnecessary or disproportionate. For instance, kidney dialysis. If people are on kidney dialysis, unless you get a kidney transplant, you know that eventually the kidney dialysis will even become ineffective and you'll get sicker and sicker. A person at that point in their life has the right to say, that's it, no more. And it's perfectly ethical to say that, because the burden of the kidney dialysis is starting to outweigh the benefits, and you're getting sicker and sicker. Also, chemotherapy. People have the right to refuse chemotherapy. They have the right to refuse multiple chemotherapy. Oftentimes, people will, or a patient will go into a first round cancer treatment, but then when the tumor, the cancer comes back, they're offered a second round, and they might say, no, I'm not going to do that again. They have the right to refuse. That is not euthanasia. Also, letting someone die naturally. Removing a heroic measure to return someone to their natural state, to allow them to die naturally, is not euthanasia. And I think a key word here is intention. If you want to discern whether something is right or wrong, part of the discernment process, and it always is a discernment process, medical treatment, how far do we go, what do we do, what is ethical, what is unethical. A way to determine or discern is intention of the heart. What is the intention behind this action? Is it to kill the person, or is it to ease their pain? Is it to kill them, or is it to remove the life support so that they are returned to a natural state so that they can die peacefully because they have multiple health issues going on? So intention of the heart is a good measure for determining whether something is right or wrong. And also, when disproportionate treatment is withdrawn or withheld, the intention is not to cause death, but it allows the person to die of natural causes. Okay. And also, the administrations of drugs appropriate to the relief of pain is not euthanasia, and I'll talk a little bit more about that on palliative sedation. And one thing I want to say here is that the Vatican over the years has come out with really good work on euthanasia. And I actually use one of the documents when I work with patients when they don't know, is it okay to disconnect this life support or is it not? And there's a good document out there, it's called the Declaration on Euthanasia. And it's written by the Congregation for the Doctrine of Faith, and you can actually find it online. And the headings are the value of human life, euthanasia, the meaning of suffering for Christians in the use of painkillers, because painkillers can be abused, and due proportion in use of remedies, so that's balancing due proportion treatment. And so I find that it's a very good resource, and it's helped me when I work with patients to help them to know what's right and what's wrong. But one thing, when analgesics, back in the 1950s, I think it was Pope Pius XII, came out with, he talked to the doctors, he gave a talk to the doctors, I can't remember what group it was, but it was back in 1954 when anesthetic and advanced analgesics were discovered. And it's like, how much is too much? And that's what they wanted to know. And so he came out with a document, and part of that document from 1954 is the Declaration on Euthanasia. And he states that it is also permissible to make do with the normal means that medicine has to offer. So that means you don't always have to accept the heroic interventions. It's okay to just accept the normal means that medicine has to offer. Therefore, one cannot impose on anyone the obligation to have recourse to a technique which is already in use, but which carries a risk or is burdensome. We have the right to refuse burdensome treatment even from the start. And some people, for instance, a patient who might be diagnosed with ALS, and they know that eventually their body is going to become paralyzed. Typically what happens is when they're unable to swallow, they ask for a feeding tube. Then when the lungs freeze up, they have a trach and they get put onto a machine. And that's basically their life support until they die. What many ALS patients will do is say, no feeding tube, no machine. I want to die naturally. When ALS takes its full course, I want to die naturally. And so they have the right to refuse, but yet continue with normal medical intervention. And so in a case like that, you'd have to make darn sure that there was very good palliative care intervention happening, because what you don't want is someone suffering or gasping for air at end of life. So there is, to refuse treatment that carries a risk or is burdensome, it should not be considered, or you can consider it an acceptance of the human condition, so long as the normal care due to the sick person is not interrupted. So that means that if you say no treatment, no heroics, you can do that, so long as you are cared for with what you're obligated to receive, nutrition and hydration, and any means to keep you comfortable till end of life. That has to continue. So what is assisted suicide? So first of all, assisted suicide typically does not happen. It's available, but most people have suicide by the doctor's intervention. But in the case of assisted suicide, the person is given a prescription or information on how to kill themselves, and then the patient takes the prescription to a pharmacy, and a pharmacy that has agreed to cooperate with MAiD. The pharmacist has to know that the prescription that they are filling out is for this person to kill themselves. And then the person goes home and they take the drugs and then they die. But what they've been finding is, for the few people that have been opting to assisted suicide, is that the stats are low in that when they get the medication, they go home and they put it in the shelf or the medicine cabinet and they don't take it. And what we've discovered is that when they realize that they have control over their life or death, that's all they wanted. And they usually don't go through with it, right? And also the statistics for assisted suicide are lower because the person might at the end change their mind and say, I'm not going to take it. Whereas in the case of euthanasia, by the doctor-assisted euthanasia, typically once momentum is set and the family's there, the person's there, the doctor's there, the IV bag is set up and the needle's about to go in their arm, it's less likely that they're going to refuse because it means stopping everything, right? Okay, so what is palliative care? Palliative care alleviates suffering through a combination of medical, spiritual, emotional, and social support measures, and it requires a team of professionals. So typically, when I ask this question with patients if they know what palliative care is, they say it's the 5th floor at St. Paul's Hospital. And I go, well, that's a palliative care ward, but it's not palliative care. And so I often do a lot of teaching at the bedside of patients who are at end of life. Doctors don't necessarily talk to patients about palliative care. They will try to treat them till end of life, and then they make them what's called CTC, which is continuous terminal care. And that's when death is imminent. A person can be palliative care for years. It's like a state of being, a diagnosis or a state of being, in that you will continue with comfort care measures, but you are no longer seeking life-saving measures, right? That's palliative care. And it also is free, which is a lot of people don't understand. That it means your medical bills, your hospital stays are all going to be covered. And that's why a doctor needs to talk to his patients about palliative care, because they need to fill out the form that gets sent to the government. Because a lot of their medications and everything is going to be free. And for someone who's palliative care for a number of years and typically not working, it can be a financial burden if they don't have that freedom, right? And so when you measure that free cost against euthanasia, which it's cheaper to kill people than it is to care for them because it takes a medical team, it takes an intervention. When my mom was palliative care and when she was close to end of life, the palliative care team, the home care nurses were driving out to the country to help support us. And one of them shared with me and she said, you know, it takes a village to bring someone to a good death. And it does, it takes a village. And when you see, like, they need medical intervention, they need social supports, they need spiritual care. The palliative care team at St. Paul's Hospital usually comes with, you know, the doctor, the nurses, the spiritual care, and the social worker. They walk around as a team. And that's costly. And unfortunately, the first year that euthanasia was legalized in Canada, of course, our government had said that they would continue to support and promote palliative care. But the very first budget that came the following year, $0 went to palliative care. Nothing. And yet there was an article in the medical journal, a doctor had actually figured out how much it'll save, how much euthanasia will actually save the healthcare system in costs. And so he had figured it out down to dollars, how much euthanasia is going to save. And articles like that, people read that and they think, yeah, you know what? To actually die, pick a date to die is actually cheaper in the healthcare system. Awful way to think about equating people's lives with dollars. In Saskatchewan, we have 3 palliative care doctors. In all of Canada, only 30% of people have access to good palliative care. I did a dying healed workshop in northern Manitoba, and it was actually spread across northern Saskatchewan. And when I talked about palliative care, they had no concept of it because they don't have anything up there. They don't even have properly trained home care nurses. And so patients in the northern communities are discharged and sent home by their doctors who say there's nothing more we can do for you. And they go home to very little supports. And oftentimes the home care nurses there or the home care staff are just barely trained. And so to talk to them about palliative care, it's like they're not even close to having that. And so there's only 3 doctors in Saskatchewan. There's 2 in Saskatoon and 1 in Regina, I believe. But yet, you can still ask for palliative care. Medical doctors can deliver palliative care. So you can still ask for it. And in Saskatoon and Regina, patients who are admitted to the hospitals there, they can ask for a palliative care consult, and then a palliative care nurse will actually come to the bedside. You'll be assessed, and if they say, yeah, this patient is palliative care, then they will take over some of the palliative care medications and any of the treatments, because palliative care treatment is very different from medically focused floors. So palliative care is about a change of focus. The focus moves from hope for a cure to hope in making life as good as it possibly can be right until the end. And palliative care also doesn't prolong life, nor does it shorten it. It works with the person, and it is very patient-focused care. So what about those whose pain cannot be controlled? So what's been discovered is that fear of pain is the major impetus behind suicide. People want their suffering to end, not just physical pain, but emotional pain. And that's from the suicide prevention, as they came up with the stats and saying the number 1 reason why people commit suicide is they want the pain to end. So a small portion of people suffer from pain which is difficult to relieve, but I say right now it can relieve any type of pain. Specialized pain management can get on top of a patient's pain. And this is why it's important, because the philosophy of pain care for palliative care is the right drug by the right route by the clock. And in between, if they need to stay on top of a patient's pain, they will have what's called a breakthrough dose. So that the goal is to never let the pain peak. It's always to keep it low at a level which is tolerable or eliminate it altogether. There's a quote by a doctor who works in Montreal in a children's hospital. His name is Dr. Sharif Amel, and he said, when pain becomes the argument for ending life, it is the pain that must be killed, not the patient. And I think that's so important because palliative care actually does get on top of a patient's pain. And unfortunately, what happens is a lot of patients don't know about palliative care or good end-of-life care. You can be palliative care anywhere. And so a lot of patients, when they are on a treatment-focused floor, that's a surgical floor or a medicine floor, one that is focused on treatment, you have doctors and nurses who their philosophy of care is to deliver pain meds to cure the patient so that they can go back home. In palliative care, you're not doing that. And so it's a shift of focus for doctors and nurses on a treatment-focused floor. So much so to the point where palliative care patients suffer for lack of care on a treatment-focused floor. And it's nothing against the doctors or nurses. It's often the nurses are overloaded with treatment for other patients. And a palliative care patient, their pain might be peaking and they'll put the call bell on and the nurse can't get there in time because she's got other patients. So that by the time she gets there, the pain peaks. But that's how the treatment-focused floor operates. Patients don't always get their meds on time. Another problem is, I'll be visiting with a patient, the pain is getting worse, I can see it on their face, and I say, ring for your nurse. So they'll ring for the nurse, and the nurse will come in, and they say the pain's getting bad, and they go, I'm sorry, I just gave you a dose 2 hours ago, and I can't give you anything else for another 2 hours. Can I give you a Tylenol? I thought, Tylenol's not gonna cut it. I'll call the doctor and see if he can change something. They're bound by what the doctor writes, and if it's a doctor who's not trained in that philosophy of care, they're afraid that if they die or if they give a patient too heavy of a dose of a narcotic, they're going to kill them. But yet when you realize that's actually the philosophy of care of a palliative care doctor is you're not going to kill them. The first goal is to ease their pain or the anxiety. Death might be imminent, or it might bring death sooner, but that's not the intention. So this is where a lot of people get caught up. And there's actually, I think it was the judge that was in that Truchon case where Bill C-7 was birthed, who actually said there's no difference between palliative sedation and euthanasia. And we said, oh yes, there is. It's like the Grand Canyon. But yet, it's two needles, right? But yet they're so different. So the difference between two needles is that in the case of palliative sedation, and palliative sedation doesn't happen unless a patient's pain is so severe or the anxiety is so high that they need to be sedated, not only for themselves, but for the family members in the room. Everybody's stressed out. And so the dose is given to kill the pain, to ease the anxiety, or to calm the patient. And the dosage or the amount of medication that they get equals the pain that's being controlled or the anxiety that needs to be subdued. No more or no less. That's palliative sedation. Yes, it might bring death sooner, but that's not the intention. In euthanasia, the intention is to kill the patient. In the end, after the needle is withdrawn, the patient must be dead. And an exaggerated dose of medication is given to ensure that death occurs. So I would say there's a lot of differences, but the biggest difference is, again, the intention of the heart. What is the intention behind these two doses? Because someone looks at it from the exterior and says they're the same. But if you look deeper within, you realize that it's not. The intention is not to kill the patient, but to kill the pain. There was a patient, he had ALS, and he was in the hospital for over a year waiting for a bed at Parkridge, because when you're on a ventilator, there's only one nursing home in all of Saskatchewan where they go, and that's Parkridge. And there's a waiting list to get into the ventilator floor. It's very depressing. So they live in the hospital until someone dies at Parkridge, and then they can take that bed, unless they die first. So there was a patient at RUH, and he was there for well over a year, and his wife would come almost every day, and she lived out of town. And so he had a feeding tube and a ventilator. And he was a spiritual man, but not religious. He didn't want to talk about God, but yet he did, but he didn't. And so he would respond by blinking his eyes, because that's all he had. And he would watch TV all day, and his wife would do needlework and visit with people when they come in. And so one day, he said to his wife, that's it. This is the end. I'm ready to just let go. Before that, he wasn't ready to die. And so they called the doctor, and the doctor came in and explained, maybe not thoroughly enough, about the process. You don't just turn a ventilator off because the person will die of air hunger. What you do is sedate them first, and then you slowly turn the machine off. So the doctor explained that process, and he said, and after the machine is turned off, you're on your own. They were going to return him back to his natural state. And he said, because of the ALS, your lungs are so badly damaged. We don't know how damaged they are, but you're on your own. Your lungs have to sustain you. And he knew that they wouldn't sustain him for long. He would probably die within minutes. And he said, but before we do that, we're just going to give you a needle, and it'll calm you. But he didn't explain it thoroughly. So after the doctor left, the wife sat and thought about it for a while, and she thought, I think he just asked for euthanasia. And she mentioned it to her husband, and he blinked like, no. And she called her son. She was so distraught because she thought that he was going to be euthanized by the doctor, and then the machine was going to be turned off. And so a couple of days later, I came in the room to visit, and she said, I want to tell you this. So she told me this story, and she told me what the doctor said. And she said, I'm just concerned about the needle. And I said, well, it doesn't sound like euthanasia, because the needle, the intention of the needle is to calm the breathing, is to calm him. It'll sedate him, because you can't just turn a machine off. That's cruel. So the needle is to sedate him, not kill him. But because he will be sedated, plus the machine turned off, he'll probably die sooner than later. But the end result is he will die quickly. And she was so relieved because she didn't know and the doctor didn't explain it, and she didn't ask questions, which is often what I find with patients' families, is that they don't ask enough questions. And then they're left in these gray areas and they don't know, is it or isn't it? So living wills and advanced care directives. Living wills can be confusing and risky because it's difficult to anticipate all the possible scenarios. And I don't know if anyone here has filled out an advanced care directive. You have. There's a lot of and or, and it usually ends up confusing patients. And also, you're filling out an advanced care directive in a state of health, or presumably good health, imagining what it's going to be like if I'm not healthy, and what are the circumstances surrounding my end of life. So a lot of it is guesswork. But you want to make sure that the right thing is done. So living wills can often be confusing. A good living will, a faith-based advanced healthcare directive. The Catholic Health Association has actually put this out. You can get it online. I do have copies here if anyone's interested. I just charge $5 for them. But a faith-based healthcare directive is probably the best one, and you want one that's very clear and straightforward and not confusing. I've often been asked to help fill out healthcare directives with patients and tell you it's confusing. And it's also frightening because you're imagining end of life, or what happens if I have an accident and I need to be put on life support, right? It can be frightening as well. So a living will or a proxy directive is a case where, and I'm not saying living wills aren't good, they are good, you do need them, and it's important to have them so that people know your intentions. In the case of a proxy directive, that's where the person appoints a family member or a spouse or someone to speak for you in the event that you're unable to speak. And some of you might have found yourself in a position where you're the proxy and you're the one that has to direct. In a case like that, what is suggested is that the person directs someone who's on the same page as you like-minded, and you know exactly what that person wants, because in the end, when the patient is on life support and unable to speak for themselves, if the doctors start asking questions, it's the proxy that has to know, I know this is what they would want, or I know this is what they would not want. And oftentimes at the bedside, especially at end of life, when there's a parent on life support and things aren't going well, and it's usually after 72 hours, and someone's put on life support, in the case of some type of an accident, whether it's a physical accident or cerebrovascular or pneumonia or something. Usually after 72 hours, doctors are looking for a shift to the good. And if they don't see that, or a shift down, they start talking about the possibility of disconnecting life support. No one is left on life support indefinitely. It doesn't happen. And I know that that's a tactic that the right to life, or the right to euthanasia, or death with dignity, they like to scare people in believing that one of their reasons for euthanasia is because, well, you'll end up on life support for the rest of your life. And it's like, no, nobody ends up on a machine for the rest of their life. In fact, if anything, it's the opposite. The doctors are pushing, the families are holding on. Not yet, right? But to understand that in that moment, it's the proxy directive, or if it's a family that's on the same page, it's so important to talk, to ask questions, and to discern that the decisions that are made at the bedside or in a family meeting, because there's lots of family meetings, there's time to discuss and hear, that it's so important to always look at what is the intention behind this action. What are we trying to do here? And then lastly, I want to mention about DNR, or do not resuscitate. I found that, and I'm not speaking against DNR, they're important, people have that, because a DNR is a directive that the patient gives to the doctor. And any request in the hospital is meant to be patient-directed. Even asking for MAiD, it needs to come from the patient. It can't come from the spouse or the daughter, you know, can you please talk to dad about MAiD? It's like, no, it has to come from the patient. In the case of a do not resuscitate, the patient discerns or decides themselves if they are in a state of life, maybe they're aged in their 90s, or maybe they have a lot of health issues going on that when they're in the hospital for whatever, if their heart should stop beating or they stop breathing, they do not want to be resuscitated. Everyone has the right to state that, and it needs to come from the patient. Unfortunately, when killing our elderly and our most vulnerable becomes legal, it erodes away at respect for life. And what happens is when healthcare staff start advertising MAiD, which is available like a treatment, when a patient comes in who's elderly, there's a coercion now that's happening to get them to sign DNRs. And it's not patient-directed, it's doctor-directed. I got a phone call one morning, it was from a lady. Her father was admitted to the hospital and she was told to go see her father and get him to sign a DNR. And he was in the hospital for an illness that was very treatable. And he was an elderly man, he was retired, and in the early stages of dementia, but he still had full capacity. And he said no. He wanted to be cured, go back home and live his life. And so, in the middle of the night, the attending physician calls the daughter and berates her, calls her a cruel daughter, that she was allowing this old man with dementia in a hospital bed to live. And so she was in tears and she said, my dad is not an old man with dementia in a hospital bed. And of course, again, I'm angry. And I said, does your father have full capacity? And she said, yes, he does. And I said, well, it's not the doctor's prerogative. If your dad says no, then it's no, and they have to fully treat him. And she said, I know that if my dad was coerced into signing a DNR, that after that it would become the doctor's prerogative as to how my father would be treated on all subsequent visits. And so the erosion of respect for life is turned from a patient-driven care to a doctor-driven. And people who are elderly or have comorbid issues, disability, dementia, when they come in with COVID or some other illness that it's going to look like an extensive stay in the hospital, the mindset shifts to, why is there no DNR on this list? Why is there no DNR on their chart? And it's like, because they don't want one. They want to be treated and go back home. But something to keep in mind is that when someone signs a DNR, and for good reason, it's because, yes, I'm at end of life, if my heart stops beating, let me go. If you're treated and go home, every subsequent visit, it will be the doctor's prerogative, whether he treats you with something or not, or says, no, this person's DNR, I'm not going to go this extensive with them. Okay? Just something to keep in mind. A DNR is meant to be a discussion and a direction to the healthcare staff, not a coercion. Right? And so just quickly here, I just want to go back to, okay, I gotta go back. Okay, what is dignity? This is how dignity is eroded. Catherine Frazee is a disability rights advocate, and she's got a blog on the internet. She's actually was very vocal when the government was legalizing euthanasia. She was very vocal because she was concerned, because she's a paraplegic. And so she says that, I don't believe that anyone should take a position on medically assisted dying without first understanding what dignity is and what it isn't. And basically what she's saying is that Do the elderly and disabled have dignity, or when they lose their abilities, is that dignity removed? How do we measure someone's dignity? And secular society actually started identifying dignity as extrinsic qualities, meaning that as soon as I lose my ability to walk or talk or feed myself, or I can't toilet myself, they refer to that as a loss of dignity. And those are all physical abilities. True dignity is inherent in us when we're born. It's intrinsic. And that is for us to be able to, okay, let's switch here. True dignity is the capacity for us to experience that which is beyond us. It's called transcendent, and actually it's tapping into that connection that we have with God. It's that God-given capabilities to experience love, truth, goodness, justice, and beauty. The problem with this definition is that someone who's spiritual and believes in that dignity is actually inherent in us. And when you go into a long-term care facility and you see an elderly person sitting in a wheelchair, probably wearing an adult diaper, do we look at them and say, they're no longer dignified? No, we never would. We'd say they continue to be dignified. Why? Because to some extent they can still experience truth, beauty, goodness, and justice, right? They can still experience that transcendent. Secular society can't understand that because they are scientific based, so they measure what they can see. They can't measure transcendence. They can't measure what's intrinsic. They don't know how, so they don't go there. So that's why the whole secular society's view of dignity is just basically the physical abilities, and once they start going away, then you have the right to die if you so choose, because it's considered a loss of dignity. The church used to be a respected voice at the table in the government. It used to have a respected voice. But the church is now viewed as irrelevant, an irrelevant voice, especially because they're contrary to what is legal now in Canada, and that's abortion and euthanasia. And the church stands against that. The Christian churches stand against that. And because of that, the voice of the church has now been considered irrelevant. So what do? Okay, so this is Daniel in the Lion's Den. And I was inspired one day because I have a group of volunteers, and they were all canceled during COVID, but when this is done and over, I'll get them back. So when MAiD came out, when it first was legalized and we fought, letters were sent, and I'm sure many of the churches, they signed up, I think there was about 50 churches that got together and signed a declaration against euthanasia, and then again, Bill C-7, there were about 50 Canadian churches that all signed the declaration again against it. And so a lot of effort, energy was put into petitioning the government, speaking out against it, talking to our MLAs, writing them letters. And it takes time and energy, but it also takes away from maybe the focus that we should have now that it is legalized. And so I use Daniel in the Lion's Den to kind of get this point across, because there's the problem and then there's the solution. And if you notice, Daniel is not looking at the problem, he's looking at the solution. And so in society today, we have very vulnerable people in our communities, in our hospitals, experiencing isolation, especially now, loneliness, despair. In the first year that MAiD was legalized in Saskatoon, there was a lady who called the MAiD line. It's a 655 number. You can call and ask for someone to come and assess you. It was an elderly lady who lived alone in her home. So she called the 655 line, and the MAiD doctor sent the anesthesiologist to go assess this person. And when he went there, he had a good visit with her and took his assessment and then left. And so on a subsequent visit, he went to tell her that she didn't qualify to die. But when he got there, she said, I don't want to die anymore, because she had a good connection with him, a good visit. And that's what she needed. She was lonely. And this is one of the points that the MAiD doctor was trying to get across to us chaplains is, what do we do about these people? I said, well, you have to let us know. You have to let us know that they're there. And so this anesthesiologist said, well, I have to keep visiting this lady now because, so that she doesn't want to die. And I just thought it's so ironic that the hand that was coming to kill her actually saved her. And so there are people that are opting for euthanasia because they're lonely. And the first thing I thought of was with this lady, where's her family? Where's her community? Where's her neighbors? Like, where are they? I know that we can only reach out to people to the extent that they let us know that we're there, but is there something that we can do to an outreach, even through our parishes or even our own neighbors, like checking in on our neighbors? Stories that I hear at the bedside are afraid. The big one is, I don't want to be a burden to my children. That's a huge, huge complaint. And when a doctor comes around and advertises MAiD, if the person feels that they're a burden to the healthcare system, I often hear too, oh, there's someone sicker than me that needs this bed. And I think, no, you deserve this bed just like anyone else. You're a human being. You have a right to this bed. And so advertising MAiD, it's like, picking off ducks, because you have people that are experiencing a lot of loneliness, despair, uncertainty about where they're going in the future. They fall at home, they get admitted to the hospital, and then it's realized they can't go back home. They have to go into long-term care. They don't know where they're going, and they're scared. So you realize that when people go around advertising MAiD, it's like, yeah, it's easy pickings. But if we focus on the problem, it's taking us away. We've already been there, we've done that. So now, where do we put our energy? So, palliative care, hospital ministry, extraordinary ministers of the Eucharist if you're Catholic, one-to-one visiting, long-term care, community, be part of someone's village. If we get really good at that, we can change the statistics for that. That's how we cure it. That's how we solve that problem. Instead of looking to the lines and trying to fight MAiD head on, we do the opposite. And that's why we need people. We need people to go out and fill those roles. Volunteers. And so my Dying Healed program is actually an impetus to get volunteers trained and out there in a lot of those ministries, or even connecting with your next door neighbor. Something as simple as that. And so my Dying Healed workshop, just to put a plug in, it was developed by an organization called Life Canada, and they do have a website. And this actually was very timely. We were wondering how, in the diocese, how can we start getting a good palliative care and respect for life message out there? And lo and behold, Life Canada came up with a workshop. So we bought the program. Regina Diocese bought the program, and PA we've taught in that diocese as well. And it's open to anyone. And we've had a lot of different faiths join together, which is wonderful. It's a concept that explains how a person can pass from this life healed, not physically, but mentally, emotionally, and spiritually. And it goes in depth and it talks about human suffering, which is a really tough sell. People don't understand human suffering now, and that it's just a part of humanity, right? It also teaches human dignity and the power of human presence. Volunteers or people have no idea of the power of their presence in a room with someone who needs you. They think that they have to be visiting, or it has to be something fantastic, and it's like, it doesn't. The power of presence, just you being in that room with that person, is already powerful, because it tells that person that you're visiting, someone cares about me. Just as simple as that. And then it also talks about pastoral approach, practical visiting tips, and then it promotes volunteer positions, and it just kind of goes into a few volunteer positions that people can do. So we teach this throughout Saskatchewan, and it's available on our website. I do have some pamphlets here with my card on them, if anyone's interested. But it's a full day workshop or 2 consecutive evenings, but it's a very good workshop. So that's all I have to present.